Okay, go ahead and start.
Recording in progress.
Good afternoon. This is Dr. Brian Carter speaking to you from the campus at the University of Missouri Kansas City School of Medicine. And I have the distinct honor to introduce our dean, Dr. Mary Ann Jackson, who will introduce the lectureship.
Thank you very much, Dr. Carter. This lecture series goes back to Dr. Jerry Burton and Patricia Burton, and our first dean, Richardson K. Noback. Dr. Burton has long been recognized as the very first graduate of UMKC School of Medicine. He joined the inaugural class of 18 students in 1971 when 9 students were admitted with what we called then advanced standing, and he graduated in 1973. In fact, Dr. Burton, who had a doctoral degree in pharmacology, was both a student and an instructor in the earliest years. After graduation, he trained in internal medicine and pulmonary medicine and practiced locally here at the Overland Park Regional Medical Center. After retiring, Dr. Burton taught the history of medicine course in the humanities department, which had opened in 1992. In 2013, Dr. Burton and his wife, Patricia, were married after Jerry graduated, and Dr. Pat Burton, who started her career as an ETC at the School of Medicine, later completed her PhD in psychology. And along with Dr. Jerry, they were persuaded by Dr. Diamond, our first provost, to author a book on the history of the medical school. This book, which lists the publication date of December 25th, 2014, was just a month, a little bit more than that, after the untimely death of Dr. Burton. It's titled A Proven Experiment Looking Back at the UMKC School of Medicine, and it includes the voices of graduates and UMKC leaders, centered around Dr. Diamond's vision of the academic plan of this very unique 6-year BA/MD program and our advanced standing program. Dr. Jim Risco, who graduated from UMKC in 1975, was close friends with both the Burtons and with our first dean, Dr. Richardson K. Noback, who funded the lectureship in their honor. And on April 28, 2016, the inaugural lecture, entitled The Art of Storytelling, was given by physician author Dr. Patrick Taylor. Dr. Risco said he chose Taylor as the inaugural speaker because the author was his favorite writer after Mark Twain, saying that he wanted a lectureship to be about what doctors do inside and outside of medicine. Dr. Taylor earned his medical degree in Belfast and practiced in rural Northern Ireland before specializing in OB/GYN, and after immigrating to Canada, he pursued a teaching and research career in human infertility. But where he really received his multiple awards for his academic work and for his outside of medicine work was when he began writing monthly medical humor columns and became a book reviewer for Stitches, the Journal of Medical Humor. He wrote a series of Irish country novels revolved around a character who was an Irish country doctor who practiced in a fictitious Northern Ireland locale. Read from his book at that lecture and gave advice to students, telling them to have fun and that he hoped the humanities faculty brought a personal touch to the program. This lecture was followed with 2017's Ways of Seeing, Ways of Knowing, a role for humanities in medical education, where Dr. Orno Kamaji, Vice Chair of Education at the University of Toronto, presented that lecture, and in 2018 with Dr. Jeremy Green from Johns Hopkins presenting the challenges of new media and focusing on the electronic patient and medical record. In 2020, Dr. John Lantos from our own Children's Mercy and the Bioethics Institute spoke to us on the topic of the value of doctors. We are grateful to honor our history and to recognize Dr. Noback and Patricia Burton. And this year, we are privileged to have as our 2021 speaker, Dr. Kevin B. Churchwell, President and CEO of Boston Children's. I'll now turn it over to Dr. Brian Carter, our Department of Medical Humanities and Bioethics Chair and the Endowed Series Professor, for the introduction of Dr. Churchwell.
Thank you, Dean Jackson, and thank you all who are attending. I have the distinct privilege to introduce Kevin Churchwell, who, as Dean Jackson noted, is the president and CEO of Boston Children's Hospital, where he provides leadership, vision, and oversight for a team that's dedicated to improving and advancing child health through their life-changing work in clinical care, research, and innovation, medical education, and community engagement. Since joining Boston Children's first as its Executive Vice President of Health Affairs and Chief Operating Officer in 2013, Dr. Churchwell has been instrumental in leading the hospital's work to become a high reliability organization, one where zero avoidable harm impacts any patient, family member, or employee. He has brought to Boston the same passion for enhancing the patient-family experience that defined his tenure as CEO of both Nemours Alfred I. DuPont Hospital for Children in Wilmington, Delaware, and the Monroe Carroll Jr. Children's Hospital, part of the Vanderbilt University Medical Center in Nashville, Tennessee, where I had the privilege to know and work with Kevin. He's an advocate for equity, diversity, and inclusivity, and is responsible for establishing 3 of the 11 offices of health equity and inclusion at hospitals across the US and Canada, including the office at Boston Children's, which he founded in 2016. With the publication of Boston Children's own Declaration for Equity, Diversity, and Inclusivity in 2020, Dr. Churchwell has committed to the work required to make Boston Children's a community that's made stronger by our differences and a leader in equity for all. Dr. Churchwell is a graduate of Massachusetts Institute of Technology and Vanderbilt University Medical School. He completed his pediatric residency and clinical fellowship in pediatric critical care at Boston Children's Hospital. He is currently an associate professor of pediatric anesthesia at Harvard Medical School and is the Robert and Dana Smith Associate Professor of Anesthesia at the Harvard Medical School. Kevin, it's a wonderful opportunity, and I am so grateful to have you and to introduce you to give today's lecture.
Well, Brian, thank you, and thank you for this opportunity. So first, I'm going to try to share my screen. So success. And as I mentioned, it's a great pleasure to be here today to give this lecture. And what I'd like to do in the next few minutes, and I promise you that I've got too many slides, but we'll work through those, is to give some thoughts around issues of what it means to become a physician in the time of COVID. I don't have solutions in this talk. I hope to recognize some of the issues that are confronting us, and then talk about some of the opportunities, perhaps not solutions per se, but opportunities to improve our profession, opportunities around education, care, and that evolution in care, and to then hopefully give a few final thoughts. So I always like to start talks with a brief history. And this is just a really brief history of medicine, of course, that as we know, the early traditions of medicine started in Babylon, China, Egypt, India, in terms of thinking about medicine as a discipline. We all, I think we still recite the Hippocratic Oath that started in Greece in the 5th century. We recognize the work of Galen or Herophilus in terms of being the fathers of anatomy. By the Middle Ages, the surgical practice that inherited from the ancient, that we had inherited from the ancient masters had improved and had been actually put into a manuscript, the practice of surgery. there were areas and cities that were very much concentrated in this work in terms of producing physicians, making it a discipline. Padua and Bologna being two examples. And then I just wanted to mention that one of the issues that drove medicine was war. In that during war, people get hurt, unfortunately. And then the response to that is, how can we best treat those individuals that are hurt, that are injured, to get them back on the battlefield or otherwise? And so war always has driven changes in the evolution of medicine. A great example is the US Civil War, where the creation of army hospitals, especially in the United States, developed because of the practices. Another example is that initially during the war, the response to injury of a limb was amputation, because it was recognized that if the limb wasn't amputated, gangrene would set in, that sepsis would occur and the patient would die. But then they recognized that there were individuals, there were soldiers that survived because of maggots. Maggots got into the wound and actually debrided the wound. And so that led to other treatments in terms of aseptic technique, in terms of cleansing and et cetera, that really continue to move the discipline forward. Another part of this discipline is the idea that it wasn't really a profession at the time in the history of medicine, but an apprenticeship. So during medieval times, barbers performed surgery on customers, as well as tooth extractions. You know, it was described that for the barber pole, red was the color for if the patient was prepared to be bled, or white was the color if you were coming in to get your bones or teeth pulled. And if it wasn't red or white, and if it was blue, that meant you were just going to get a shave. But that's how our discipline progressed moving forward. And so what changed in the United States? And I think it's important just to talk a little bit about that. And so what really changed in the United States was what happened around 1910, and that was the Flexner Report. It was a report on the state of medical education in the United States and Canada. It was written by Abraham Flexner. Now, as it turns out, Flexner was not a physician. He ran a for-profit business and had a BS from a college, but he was not a physician. And how he was identified by the American Medical Association, it's still unclear, but he was identified as the person to lead this effort. Working with the Carnegie Foundation, he published his report in 1910. And his report changed medical education and, I believe, of course, the field of medicine in the United States moving forward. You know, he visited over 155 medical schools. At the time, almost anyone could create a medical school. Many physicians created these for-profit schools. There were schools of homeopathy. There were schools that basically concentrated on the use of herbs and botany in the treatment of patients. So his review was very important because his review described that these schools need to be closed, that these schools were not at the standard. And he identified one particular school that was at the standard that he recommended all schools follow, and that was Johns Hopkins. Hopkins at the time was following the model of schools in Europe. And with that, the model of medical education and care actually was derived moving forward. And so Flexner's report described there were too many doctors, too many schools. And so half the schools, more than half the schools were closed. Now, there's a positive of that, and that there was an elevation of the discipline and elevation of it becoming a profession in terms of identifying the course of medical training. But also important, in closing those schools, there was a reduction in opportunity. Prior to that time, females were becoming more and more involved in medicine because of the opportunity to go to these types of schools of medicine. They were closed. And with that, the opportunity for females to actually become physicians decreased significantly. And of course, in terms of African Americans, with the reduction of the opportunity, those that wanted to be physicians had a significant decrease in opportunity, to the point that Flexner recommended that of the 5 schools that admitted African Americans, 3 should be closed and only 2 left open. Those 2 were Howard and Meharry, open to this day, remaining open to this day. But with that, there was, as you can imagine, there was a change in terms of who could become a doctor, why they became a doctor, where they came from, in terms of their socioeconomic class in becoming a physician. I let that this last bullet describes Flexner's view, which actually imbued the American Medical Association's view, and that Black doctors should only treat Black patients and should play a subservient role to those of white physicians. In reality, that continued to be the case for a significant period of time until the 1960s, and changed dramatically with Medicare. And that's a story for another day, and maybe we'll come back and talk about that story, because that's an incredibly fascinating story also. So with the Flexner report, with the change in medical education, and how individuals became physicians, I believe that medicine became a true profession. It's that classic view of the single practitioner and the importance of the doctor's bag, the importance of the physician as that caregiver that was responsible for his patients. It's responsible for all aspects of their care, who dedicated their lives to that. A bit romanticized, but I think extremely important in terms of medicine as that profession that we all aspire to and are part of. You know, I'll spend just a little time talking a little bit more about that from the humanities standpoint, in that throughout the history in the 20th century, this romanticization of the physician was really expressed in many different ways, through novels, through the movies, through television. And I just want to give 2 examples that sort of hit home to me. There's a classic book called The Citadel, written by A.J. Cronin, a British physician. And in that book, the protagonist is Andrew Mason. He's described as an idealistic, newly qualified physician. And Mason gets into practice, becomes a physician for what we would describe as all the right reasons. He wants to help others. He's dedicating his life to that. But as the book describes, he's seduced by the easy money from wealthy clients rather than the principles he started with. And through the book, we see this. There's a great miniseries that was created from this, from PBS. Ben Cross, his pictures in this book cover, plays Andrew Mason. And in the miniseries, it's not because a patient dies that things change, but it's because Mason takes on the responsibility, because he has to take care of Welsh miners working in the coal mines. And he recognizes, because of ineptitude, because of uncaring, these miners were dying from silicosis. And there's a great scene where he realizes his responsibility and how he has not met the standard. And he starts to pound the table, realizing that his life needs to change, and he needs to go back to where he started in terms of being that physician, being that profession, and the importance of medicine as a true profession, responsible to society, responsible to the care of his patients. I think another example, which is incredibly melodramatic, is from the book written by Lord C. Douglas called The Magnificent Obsession. So just bear with me a little bit. This book has been changed into movies, to a movie twice. And I put them both up here. First, just to recognize Irene Dunn. I don't know if you ever get a chance, the actress Irene Dunn is a wonderful actress. Ever get a chance to watch her movies, and the ability to to do drama, to do comedy, and to also sing. She actually was in the first Showboat, the movie Showboat, and sang in that movie. But she, along with Robert Taylor, were the principals in the first movie of The Magnificent Obsession. The second movie is the movie that I grew up seeing, and that's the one with Rock Hudson and Jane Wyman. So the plot of the book and the plot of the movie is this. Rock Hudson is a playboy, and doesn't care about life, doesn't care about others, just cares about having fun. And he has a speedboat, goes out on the lake one day, just racing his speedboat, and creates an accident, causes an accident. And in the accident is Jane Wyman and her husband. Now, the problem is that with the accident, her husband is critically ill. And for some reason, there's this machine that they call the resuscitator. And Jane Wyman's husband dies because they can't find the resuscitator. It's not available. It's not available because of Rock Hudson's issue with causing this accident. Well, because of that, Rock Hudson feels guilty and begins a relationship with Jane Wyman. Turns out she's blind also because of this accident. And he does everything in his power with his money to try to help her, to try to regain her sight. But nothing that he can do in terms of who he is as this playboy can help. But Rock Hudson has a mentor, and his mentor is trying to help him try to help him work through his grief, but also try to help him evolve as a human being. And at some point in his life, Hudson decides that he wants to change. And in doing that, he wants to become a doctor. And he wants to do that and ultimately maybe help Jane Wyman down the road by becoming a doctor, a true physician. And when Rock Hudson tells his mentor this, his mentor describes that what you made an incredibly important decision in your life to pursue this career, this profession of helping others. It will be a magnificent obsession. That's where the title of the book comes from. And so that's what happens. Rock Hudson becomes a physician, and oh, by the way, he becomes a neurosurgeon. And there's this great scene in the book where over a period of time, he does his residency, becomes an attending, becomes a well-known neurosurgeon. And in that, he has all the presentation of anyone you would want to have as your doctor. He's calm, he's kind, he's incredibly confident, and he's compassionate. And he just happens to run into Jane Wyman and realizes that he can help her. And at the end of the movie, he actually does the operation to restore her sight. Great movie, but really describes, I think, the idea around the physician as that professional, that the importance of its profession. The last picture here is from another movie that I would ask you to, if you ever have any time, see. It's called The African Doctor. It's a small movie produced overseas. It's a true story about a doctor from Africa who does his training in Britain and then looks to find a job. He decides not to go back to Africa, to Zaire, and gets recruited to be the physician for a small French village. He brings his family there, and the story is about how he works to be accepted as the physician in that village, and his family becomes accepted. It's a period of episodes, and it turns out the most important part of the acceptance was that his daughter could play soccer and help the local soccer team. But I think it's a wonderful movie because, again, it describes this physician's journey, his dedication to his craft, his dedication to his profession. And there's a great scene at the end of the movie that describes how after his acceptance, he's called all the time for help. And there's a scene where he's sleeping, he gets a call and his wife wakes him up because this is their routine for him to go and take care of the next person in the village. So this is what the evolution of the opportunity of we as physicians and what it means to be a physician, our dedication to society and the dedication that we have in our profession. So what's changed? What has changed? And I will tell you that probably nothing has really changed, but the challenges that we continue to see and have to encounter in this this time of COVID, I think have brought many issues to bear. These certainly aren't all of them, certainly aren't all of the challenges, but I'd like to just talk a little bit about a few of them, talk a little about them, but also talk about maybe some solutions to them. The challenges around the information overload in medical education and care that we see, the challenge around shift work and handoffs, the challenge around time commitment, the work-life balance issues, and the expectations from society. You know, as I mentioned, I'm not going to have all the time to talk about all of these, but I'll try to hit on a few of them. So I'd just like to talk a little bit about the challenges around information overload in medical education and care. That's a big challenge, right? The growth of knowledge that has occurred has just been tremendous. Rapidly advancing medical knowledge now, the doubling time is now 73 days. The population that we're responsible for is aging. There are more people with chronic disease, disparities, and we're finding the ability, how do we find that ability to prevent disease? You know, there's a slide that really shows this, the doubling time of medical knowledge. In 1900, it was calculated the doubling time was 150 years. By 2020, it's now to 0.2 years. So how do we keep up with that? How can we keep up with this? Well, at Boston Children's, we're addressing it in a couple of ways. One is the creation of what we describe as the Boston Children's Hospital Academy for Teaching, Education, Innovation, and Scholarship. And it's an opportunity to really have the conversation and the discussion around what can we do to help? What is it going to take to help our physicians, our practitioners, our residents to learn about where they are in this world of medicine and support what is happening to them in terms of this information overload. So the idea of this academy is to promote excellence and innovation, to offering mentorships and support. The idea is around career development, to help facilitate that, and to promote interprofessional and multidisciplinary educational programs. You know, the goal is to share the best teaching methods. How can we actually, recognizing these issues, what are the best methods to teach to support that education? And so in this academy, there's a lot of excitement. I think we've been really successful in bringing multiple groups together. And this slide just shows it's not just for the physician, but we have nurses, we have pharmacists, we have social workers, we have nurse practitioners that are part of this academy to break down those silos and to provide the opportunity to address this information overload. Another way that we're thinking about and what has been established in terms of dealing with this information overload in medical education and care is how do we actually utilize the web? How can we use the web to support this work? Well, if you go on the web, you can type in Open Pediatrics. Open Pediatrics is a web-based platform for evidence-based peer-reviewed education. Specifically, it's utilized for children with critical care illness. The idea being that there's a lot of information out there. There's a lot of ability to diagnose, and there's a lot of care that is being developed instantaneously. How do we help the practitioner keep up with those opportunities? How do we help the practitioner learn how to take care of the patient that's right in front of them? And how can we use the web to do that? Well, Dr. Jeff Burns, our head of the Division of Pediatric Critical Care and Anesthesia here at Boston Children's, along with his group, have taken on this task over the last 10 plus years, creating lectures from experts across around the world on particular topics that are easily accessible to the practitioner. You could be here in Boston, you could be in Kansas City, you could be in Santiago, Chile, you could be in Melbourne, Australia, or you can be in Poland. And what if you had a web connection? If you have a web connection, you can be connected to the experts in the field for the care of the child that's in front of you. The example that's being scrolled through is how do you use a ventilator and how you can utilize it for the care of the child with pneumonia or congenital heart disease. And it walks through these modules and says, if you do this, this is what happens. If you do this, this is what happens. It's incredibly exciting. and continues to grow in terms of the opportunity to connect everyone and to provide the opportunity to deal with this, what we describe as this information overload to education and to care. Another example that Open Pediatrics has done is the work with COVID, and that they created these opportunities for communities to learn in real time what's happening in COVID, the most up-to-date care opportunities for our kids and for adults, and also provide just-in-time learning for everyone who had a web connection. And so you can see this opportunity to create this type of web-based real-time education is quite exciting, and I think an opportunity for a solution set to the challenges that we see. Another opportunity for this challenge of information overload in medical education and care is the work in simulation. So, when I was a resident and a practicing doc, we describe simulation as the opportunity to learn how to do a particular procedure, right? You'd go to a particular room, potentially not a well-lit room, and there would be mannequins there, and you could practice your intubation skills, and that was simulation. Well, it's changed dramatically. The leader of simulation here is a doc, Peter Weinstock, and his view and their view of simulation is changing my view just dramatically of where the great opportunity is for it being part of providing information, providing education, and providing care. Now, he woke me up to this by a particular lecture he gave where he started out by talking about golf. And he talked about how all the great golfers practice before they hit the ball. And he had a picture of a famous golfer practicing his swing over and over, then he would hit the ball. And with that, he would be consistent in terms of his addressing of the ball. And he described that as, that's how we should think about simulation, not just once in a while, but an activity that can occur all the time for us to improve our practice. And so with the time sinks that have occurred, with the stress related to the amount of information that we have to coalesce and bring to bear in terms of education and care, simulation is a great opportunity to actually help us in that regard. It provides the opportunity for immersive training. It provides the opportunity for immersive system design and human factor design. What I described as that poorly well-lit room in terms of where you would go to intubate someone, it's changed dramatically. I'm sure you have it at your medical school, your simulation environment. In our program, it's a program where the operating rooms that are utilized for simulation are as real as our regular operating rooms, to the point that they've been utilized to film movies in them. And they're utilized for the teams to come in and do scenarios and do the work of actually learning about the opportunity. And so it's evolved from just the mechanics of practice to this mechanic, to this pyramid that's in front of you, where we think about the opportunity for simulation to create an environment of psychological safety, where individuals and groups can actually question what they're doing, why they're doing it, in a way that is less pressurized, that doesn't have this dynamic of stress related to hierarchical stress. And in that, these teams can improve their care, improve their learning around around really important situations. We've utilized it. You see the picture on the left, on my left anyway, for the development of space within the hospital, creating an environment where what's the new critical care room or operating room, how should it look? Well, let's put some cardboard boxes up and let's put our teams in that room and really play out how the room looks now and how we want the room to look, how the room needs to look. All this is a great opportunity for education and for improvement in care in our environment. So in our pyramid, we start with psychological safety, and we work our way up from basic skills and orientation to working in our environment and processes, to working with teams, education of teams, and review of issues. And then we've gone to live event analysis and debriefing, taking the time to talk about what happened, why it happened, and what we can learn from it. And gone to specific patient simulations. And that's where we're headed in terms of this type of education. I think it's wonderful. I think that's where their future is. And I think it's part of our solution set in terms of the challenges that we're seeing in our environment. With COVID, one question comes up: how did you do simulation of COVID? Well, they figured it out. They figured out how to do hybrid sim, safe sim, solo sim simulation to continue to utilize the web, utilize our resources, utilize telemedicine, teleconnect to make it happen. So it's our future. It's I think a great opportunity, and I think it's part of the solution set that we can move forward. So given that, I just want to go further and talk a little bit about other challenges the physician faced in this time of COVID. And that's, I think, one we would all agree upon is that the challenge around shift work and handoffs. I have a few slides about this. We see it in our hospitals. I'm sure you see it in your hospitals and medical school. I think it's one of the most important challenges that we face. There's history associated with this. And I just want to provide a little food for thought around that history. Not that it's totally the truth, but it's my thoughts around why we are, how we got to where we are in terms of this shift work issue, and what we need to do about it. And so I think it goes to, we always had this shift work issue in front of us. We had this shift work as an issue that we had to deal with. But certainly, I think we'd all agree that the Libby Zion case really brought it to the forefront. You can just see the slide. It describes the headlines around it. It's described as the day medicine changed forever, a life-changing case for doctors in training. The girl who died twice, what killed Libby Zion? The issues around that case and what occurred after, I think, is what I want to talk about. I don't want to talk about the case. I don't want to talk about, the merits of it. That could be another lecture. But I think the consequences certainly are worth talking about. As you remember, this case was about a young woman, a freshman at college, who presented to emergency department with symptoms, febrile, irritable, was on a particular cocktail of drugs, admitted to the hospital by a resident, supervised by a junior resident. They had a discussion with their attending regarding the plan for her care, but over a period of time, the patient died. She died. And the consequences of that were driven by her father, who wrote in a New York Times op-ed piece, "You don't need kindergarten to know that a resident working a 36-hour shift is in no condition to make any kind of judgment call. Forget about life and death." And so what happened to Libby Zion was equated to the reason being because of the state of those residents, that they were on a 36-hour shift and they were in no condition to care for patients. So in 1989, the New York State adopts the Bell Commission recommendations that residents cannot work more than 80 hours a week for more than 24 consecutive hours. But there are consequences to that commission's recommendations. It went through like wildfire throughout this nation in terms of medical schools, in terms of residencies, in terms of the requirements. A lot of positive consequences to those requirements. But there are other consequences that we are still dealing with. There are consequences that led to shifts in training, changes in training, changes in the way we do our work, and changes in the view, I believe, of the profession. So just a little bit about that. It goes to, in shift work and hands-off, many patients in our environment now are admitted to the hospital for 24 to 36 hours. And the question then becomes, who owns the patient? Who is responsible for the oversight of the patient? Who is the physician responsible? Well, there are attending physicians that are much more involved than they were previously. But I don't know if that's the solution. And I don't know if that's the solution for the continued evolution of the profession. Who are we educating? How are we educating our medical students and our residents in terms of their responsibility, in terms of how to do this? And so I think there's an opportunity to think through how we can deal with these issues around shift work and handoffs. So I'll just start with handoffs first. At Boston Children's, there's been a lot of good work around handoffs and how we can make them better. And the work has revolved around a program called IPASS. It's a program that provides what is described as a common structure for information that promotes high reliable verbal and written communication. And so, as you know, you can do your sign off or your handoff in many different ways. Sometimes it's on a scribbled Post-it note. Sometimes it's on a text message or a phone call or something you print out 5 minutes before you do sign out. And the thought is that there's a better way. There's a way we can do this from a structure standpoint that improves communication, that improves the handoff, that really describes who's responsible. And it goes to describing the handoff in these ways, describing it so that everyone understands the illness severity. It understands that gives the patient summary, that provides an important action list, that provides situational awareness in the contingency planning. And there's a feedback loop. What you're providing is synthesized by the receiver. The right side of this, my right side of this slide describes it's not just creating the document, but the work is around how do you practice this? How do you coach this? And there's work with groups really resolving around the coaching aspect, making sure that the use of IPASS is done well and improves care is the opportunity. Well, I think that we've shown that this works, this helps. This is just this slide just shows some of that evidence, reports in the New England Journal and JAMA around work with IPASS and how it's reduced harms related to handoffs and improved care. And so just one more last slide that, with this work, there's been a 70% reduction in handoff-related harms. There have been over 100 million handoffs estimated conducted with IPASS. And so I think it's a great opportunity. It's an opportunity, it's a solution set for this concept around shift work and handoffs. So next, I just want to talk a little bit about what is the opportunity for solution sets around all of these issues: information overload, shift work, time commitments, work-life balance, the expectations from society. And that's the opportunity around artificial intelligence, or what we like to call here aligned intelligence. So since with the time of COVID, what are the expectations around artificial intelligence adoption? The thought is that, and the analysis is, in 2018, there was 30% of our healthcare leaders were using it or thinking about using it. But with COVID and post-COVID, we're thinking that 84%. How they will use it with predictive analytics, clinical decision support, collaboration, utilization with specialists to improve care. The clinical decision support could be the utilization of IBM Watson and how it's utilized in cancer diagnosis. From our standpoint, we've been working with actually a major company to produce a program for radiologists who don't really see children a great deal in their profession or in their environment, specifically children who get a CT or an MRI, to help them work through what's normal and what's not normal, utilizing artificial intelligence or aligned intelligence to help them work through and identify, yes, this is abnormal, yes, this is normal. So this is just two examples of what the opportunity is. The challenges are the need for high quality and accessible data. Of course, there's a cost associated with this. And I believe the major challenge is the lack of trust in AI. All it takes is one misdiagnosis or one problem for we as practitioners to say, well, I'm not going to do that again. I'm not going to utilize that again. But not realizing that's what happens to us every day without AI in terms of what and how we take care of patients. But I think that's a major challenge. So with artificial intelligence and the importance that it should be data-driven decisions to make healthcare, especially in those complex environments, to bring that tapestry of inputs to help us bring those together to make the best diagnosis. So the first step in what we're calling artificial intelligence or aligning intelligence is we've got to couple it with the human practice in our delivery. This is probably the most important slide for me, and I'm sorry, it's a really complicated slide, but it describes what we're up against. This is a child who was in our cardiac critical care unit. So by definition, it's a really complicated child. Look at all the tubes. Look at what this child is connected to. And so this slide describes the issues around the inputs of diagnosis, risk adjustment, the procedures, looking at the acuity index. It describes the environment this child is in, the environment the physicians and nurses are in, the teams that are taking care of this patient, and the workflow issues. It also, if you look at the slide, describes the monitoring devices that are hooked up to this child, that are there to help you, provides such a wealth of information. Are they helping you or hurting you in making the decisions around what's the best way to care for this child? And then in the end, in terms of the discharge of this child, once he or she gets better, and how we can, and the information we need to make that important. So this is what happens. Inputs, outputs going everywhere. And how can we make sense of that? How can we take the practice variability that we're seeing and the standardization of care that we want, but understand that there is biological variability? And how can we pull this all together to improve care? How can we manage uncertainty and align the data with intelligence? But the idea is that artificial intelligence should help us do that. AI should be part of that. The slide describes, how are we going to get there? Well, the adaptation right now could be low because we're all about standard of care and we're rigid. And how do we get to resiliency and utilizing the immersion of that data? So the goal would be, to take the data, work it through a customized networks, a data management platform, have online analytics that the end user can utilize and plug into clinical protocols that help the treatment of patients. That's our aspiration at Boston Children, but I think that's our aspiration everywhere, to take this data to improve care. The other idea is around how do we take the digital world, use digital innovation to improve the care, to improve and address the challenges that physicians face in the time of COVID. I certainly think that using the digital world will help us in terms of the information overload we see, the time commitments, and certainly expectations from society. These changes will be driven by COVID. We believe, and I believe, necessary to care from MDs operating in a independent way to a role in a collaborative way, as the MD becomes the expert collaborator from that standpoint. And the collaboration is in multifold. We have to be able to work and collaborate from a digital standpoint, using the tools that are being created with the disruptors of medicine, of care. But we need to make sure that we are remain the general contractor, that we're the advisor for the care plans that are being created. We also have the opportunity to collaborate with the broader care teams that are being created. That our goal is to provide a comprehensive holistic care for the growing number of patient panels, utilizing everyone that's part of the team. And also importantly, in this digital world, how do we collaborate with patients where we're able to meet our patients where they are and what expectations they have as that evolves. So working with our collaborators, the disruptors, what I mean by that is working with CVS Health or Amazon Health or Walgreens, what they're bringing to the table. It shouldn't be in isolation. It shouldn't be separate from us. It should be working with them in this digital world to collaborate, to provide the best care possible. Across care teams, I think we all appreciate that these digital tools that are being produced, how do we integrate them with our teams? Nurse practitioners, physician assistants, the medical student, the residents, community health providers, working in a holistic way to provide the best care for our patients. The opportunity is to provide seamless coordination of care for the patient's journey. The opportunity is to leverage the depth and the breadth of those individuals in our community to address these clinical gaps. And the opportunity is to deliver appropriate care at all acuity levels if we're able to do this well moving forward. And then the collaboration with the patient to meet their needs, where they need it, when they need it, how they need it. Telemedicine is a great opportunity in that regard. You know, I was talking to our pediatric psychiatrist, and the evolution with telemedicine is that the patients who come to our clinic or they come and sit in their doctor's office we're actually talking to them as they're driving to Target. And we're having the visit while the patient is driving to Target, because that's where we're meeting them. And it's happening and it's making a difference. How do we leverage that? Where is that opportunity headed? I think is really important. So I know I'm running out of time, so I've got just a few more slides. And so I just wanted to talk about, given everything I've presented, I will tell you that part of this was what I would describe as a MacGuffin. This title of becoming a physician in the time of COVID, I hope you all realize that it's not just in a time of COVID that these challenges have presented to us. These are challenges that have faced us since the beginning of time. And it's really the challenge around how do we continue to see medicine as a profession? So the MacGuffin part is that, you know, usually in a Hitchcock movie, there was a plot device that everyone thought was the plot, but it actually just pushed the plot forward. So my title just pushes the plot forward in terms of my talk. But I really wanted to really address medicine as a profession and the importance of that. So no matter what, in the time of COVID or outside of COVID, I believe the issues that we're facing now are the issues that we will continue to face. But our solution set really continue to start as treating medicine as a profession. It goes back to that slide I showed about the physician as that single practitioner with his doctor bag walking across the plane. This on my right in this slide are my brothers. This is a slide that reminds me that two of my brothers are physicians. They're adult cardiologists. And how they practice is something I just want to describe to you, because it describes to me the importance of medicine as a profession. First, a story that you're probably familiar with, of what's happening in our profession today. I talked with an individual who is very much supportive of our children's hospital, and he described his history or what has happened with him in medicine. Someone he's very close to had a problem. And his decision was made that this individual be taken care of at a well-known academic institution of medicine. This individual had a complication, and so was seen by the cardiologist, was seen by the cardiothoracic surgeon, was seen by the infectious disease doctor, was seen by the orthopedic surgeon. But no one was talking. And some complication perfect, next complication to another complication. And this individual had to take the role of coordinating care. Well, he's not a doctor, right? That's not what he did. That's not what he learned to do. But he had to take the responsibility because we as a profession weren't taking the responsibility. And I think that's an issue that we've got to face head on. What is our responsibility in the care of our patients? So I put my brothers up here because I want to give a story about my oldest brother, Andre Churchill. He's the one in the middle. He's an adult cardiologist. He's also now the Vice Chancellor for Health Affairs for Equity Diversity at Vanderbilt University. But in the end, he is an adult cardiologist dedicated to his patients. And the story is that we actually were at one of our relatives' graduations in another city. We lived at the time, and I lived at the time in Nashville, Tennessee, and that's where he lives, working at Vanderbilt. And we had to go to Georgia, rural Georgia, for the graduation, a high school graduation. During the graduation, his phone rings, and he steps out and he takes the call. Call is from one of his patients, and the patient is calling him because he's ill and he needs help. And my brother takes the next 15 minutes and coordinates his care from a graduation in rural Georgia, coordinating the transport, coordinating who is going to see his patient at the hospital, talking with the physicians at Vanderbilt about what he knows about the patient, what his expectations are, and what they should look for. And to me, that was such a learning of what we're responsible for, where our opportunities are as a profession. And it hasn't changed. And what we're able to do to move this forward in terms of our challenges, I think goes back to that event, to think about our responsibility as physicians, our responsibility as professions. So this is my last slide, and I just want to leave this. Some of you may have questions. Well, what can I do? In this whole environment, I'm just one person. I'm just one medical student. I'm just this one resident. I'm just one physician. I'm just one nurse. And what can I do? Well, I just present the work of Dr. Daniel Hale Williams as an opportunity for us to think about our opportunities. Daniel Hale Williams was born in 1856. He died in 1931. He was an African-American who in 1893 performed what is referred to as the first successful heart surgery. So he started his life, one of 5 children. He started as an apprenticeship, working with a physician, decided that that's what he wanted to do, to be a doctor, went to medical school, Northwestern, graduated from there, and then made the decision to open up his own hospital. And with that, changed the lives of many people in Baltimore, Maryland. And with that, moved the discipline forward by performing one of the first successful operations on the pericardium after an individual who was injured via a wound. He became a charter member of the American College of Surgeons in 1913. One article I read about him said he died in being lost, that no one knew about it. That's not true. That is absolutely not true. And I think he's just an example of what we can do as individuals and continue to move our discipline forward. So I'm going to stop there, Brian, and I hope that what I had a chance to talk with you was helpful. And I don't know if we have any opportunity for questions, but I'll stop there.
Well, Dr. Churchwell, that was phenomenal. And we really are grateful for you putting together those thoughts. I'll have to tell you, I wrote down, I'd heard about being an expert collaborator and seamless coordination, but I wrote down expert contractor, something I hadn't ever considered myself necessarily having to be. We do have some moments for questions. People can put them in the chat, or if you want to raise your hand or just turn on your microphone, Dr. Churchwell will give us a few moments.
So thank you, Dr. Churchwell. This is Marian Jackson. Very much appreciated all of your words. And what I'd like to ask you about is your view of the COVID pandemic consequences on how we're educating medical students, residents, and fellows in this era where we've restricted their access into the clinical environment and where we've changed the dynamic about who is present at the bedside.
Yes, certainly. Certainly there's been that loss, right? That human to human connection. that we've got to appreciate, and also appreciate that this is not our future. At some point, we will be back together. And so this is a great opportunity for learning in terms of how we've adapted. And my concern is that we don't lose those learnings as we evolve the discipline. We evolve the opportunity of how we teach, what we teach, who we teach, where we teach. I think it's opened up incredible vistas in terms of those opportunities. You know, I'm part of that generation that just did it one way, right? This is the way it has to be done. The younger generations are much more adaptable. And I think we listen to them as we move forward to really meld what's best in terms of our educational opportunities. So I hope that's what we're thinking. I know that's what we're thinking about. And I hope that that's where our opportunities lie.
That's what I call the silver linings of the pandemic. There aren't very many of them, actually.
Yes, yes. I'm always a glass half full guy.
Oh, Kevin, I'll have to share. The glass is always full. It's just, it's full of air and water, but the glass is always full.
You know, that's a great way to look at it, Brian. Great way to look at it.
So could I ask a question? Obviously, you touched on telemedicine there with respect to the convenience for, say, a patient, an outpatient kind of visit, or many offices now, the regular visits even by telephone until you get to come into the office anyway. How do you see that maybe telemedicine and the COVID crisis would allow better transfer of knowledge, say, from the expertise of particular experts, say in the Boston area, working with people in rural districts of other states or something like that?
You know, I think that is the great opportunity. What we've been talking about here, and I've sort of started beating the drum, that in order for that to be realized, we have to appreciate that broadband, or the reach of the web, has to be seen as the same as the reach of electricity. The reach into communities, into cities, into all aspects of our society, that is just as important. That it should be utilized, seen as a utility. You build a road, you build the access to broadband, you build the access to electricity. And that's the way it's going to work, because that's how important it is. And I think it's showing that. You know, we had a problem about 7 years ago where we had a cyber attack. And honestly, it was by one kid. It was one kid who knew how to use the internet, who basically almost shut us down. And we realized that without the web, without the internet, we had gotten to the point that our hospital couldn't function. And so we have to understand that this is where we are in our society. And so how to realize that and the opportunity it explodes for us, I think is really important.
I might follow just really fast. I think one other aspect that has made that somewhat more challenging is that if somebody is medically licensed in one state, can they give advice across state lines, or, you know, in a state that they're not licensed in? Is that still a barrier, or is that something of the past?
No, that's absolutely a barrier. It's a barrier that with COVID was significantly reduced and really supported care. As COVID is waning, as things are changing, those barriers are being put right back up. They're barriers that I think we as a discipline need to work together to educate our legislatures, those in Congress, our payers, the importance of breaking down those barriers and how it inhibits care. You know, their concern is that we will abuse the opportunity. And, you know, that doesn't come across, right, to those that as in our profession, in terms of the importance and our responsibilities to society. And so we've got to get everyone at the same place, at the same table, in terms of that piece of work.
So you're speaking there about reciprocity across state boards for allowing privileging.
Absolutely, absolutely.
Yeah, big thing, takes a lot of energy, but well worth it given the circumstance.
Yes, the barriers have been put up because of issues around how we are paid or how the dollars flow from the federal government to the state and et cetera. But they shouldn't inhibit care. And so we've all got to get on the same page at the same table to talk about that.
Dr. Churchwell, it sounds like you're framing things for us to think about at different levels, whether it's the big policy, national things, local things, institutional things, as well as individual responsibilities as professionals. I really appreciate your insights today. If there are no other questions, we'll wrap it up. And again, Dr. Churchwell, thank you so much for delivering the 2021 Noback-Burton Lectureship. And we hope you have a nice holiday season, sir.
Thank you so much. It was an honor. Thank you so much.
Dean Jackson and others, thank you, and have a good afternoon.
Brian, thank you.
Kevin, you're certainly welcome. Appreciate your insights again, and it was wonderful to see you and hear you.
Great to see you
Maybe
again, Brian.
one day it'll be more of a physical see you, and we'll either bump elbows or fist bump or maybe shake hands.
Hey, let's plan on that. We'll plan on that. Great.
Okay.
Take care.
Do take care. Bye-bye.